And we're live in 5, 4, 3,
2,
1.
Take it away, Dr. Wang.
Thank you, Linda. This is fantastic. We are here in beautiful South Florida, Miami. I'm here at the amazing Claw Restaurant, one of the best restaurants in our town, with our University of Miami faculty. We're excited to bring to you 1 hour of amazing case presentations. Let me just give a little disclaimer that we usually do this grand rounds over an amazing dinner like this. It is unreal. We're overlooking the Miami Bay, Biscayne Bay, and our dinner will be interrupted periodically with some of the wine pairings, if you will, for our crab and steak tonight. But this is going to be truly amazing. Let me just introduce, you guys want to come back here real quick, very quickly, introduce our chairman, Alan Levy here. Alan, Dr. Michael Monterey over here, Matthew Kumick, Timur Yurikov, Greg Basil, who set all this shit up, and we're missing one other person, right? Shelby Burks, but he couldn't be here because he's in Telluride, and Ian Cote. But we're missing a couple guys, but we're going to try to make it amazing. So without further ado, I'm going to tell you we'll have some interruptions, and we'll have a lot of eating and drinking tonight. But I'm going to have Alan Levy kick us off with a keynote lecture about a very important procedure he does here in Miami. Dr. Levy?
Awesome. Thank you. And Mike and Greg, and thank you to the rest of the team for putting this together. I just wanted to say a couple of words about the Seattle Science Foundation, which I'm just in awe of. They have really revolutionized the field of education. And they've been doing this for a long time. And I just want to give kudos to them. And Linda and Rod and Rick and Jack and all of the spine surgeons, both ortho and neuro, who have helped push this along. I got to tell you, if you go to their website, they have objectives. I mean, those objectives are things like educate, innovate. But one of the things that caught my eye is their objectives is we love to do cool things with cool people. And if this isn't the coolest thing, by having grand rounds in South Miami at this incredible restaurant, I don't know what cool is. So I'm gonna spend maybe the next 8 to 10 minutes talking about this procedure, but happy to be interrupted by wine pairings and food. So you just let me know when to stop. So we're going to talk about a procedure that we've been doing here for now about 12 years. And it's called minimally invasive direct repair of bilateral lumbar spine pars, defects, or fractures, or whatever you want to call it, in young athletes. There are many mechanisms where young kids can fracture their pars. And these are my non-relevant disclosures. And so we thought, as many of us will do a case presentation and talk about how they were managed. So this first kid is a 14-year-old kid, plays baseball. Baseball is his life. He's not professional, but he wants to go to the big leagues and plays 3-4 hours a day. But something happened during a swing, and he just can't play anymore, and he's in chronic low back pain. He's tried everything. He's tried bracing, he's tried medications, physical therapy, steroid injections, and he just can't get back to playing baseball again. And when you do the imaging, he has bilateral L5 pars fractures. And this is just a little slide to tell you there's many ways to diagnose pars fractures, including X-rays, CT. CT with SAG recons is the real imaging study that to try to look and see if they're healed or not. MRI, you might see edema of the pars or the pedicle, and then SPECT scan to see how active the fracture is at. We talked about all the conservative treatments this guy had, and the important and probably most important thing of this whole talk is that most patients get better on their own, like well over 85%. So you shouldn't even be thinking about surgery until, as a last resort. And so how we developed this technique was, we saw a bunch of these kids, looked at the different options, and certainly open options of fusing L5 to S1 in a young kid is not really tantalizing, I would tell you. They have to be around for the next 70 years. The chance of them getting adjacent level disease is super high. There's been a bunch of techniques that have been described that are specific to fixing the pars without fusing L5 to S1. Many of them are open techniques. And so we were thinking, like, how could we do this with a PERC approach? And using a lot of the things that we've learned from odontoid fracture repair is how we embarked on this in 2012. And these are some of the residents and fellows and medical students have wrote about the results. Just really quickly, the technique is Jackson table, biplanar C-arm, O-arm intra-op to confirm placement of the Steinman pin. And we'll talk a little bit about how to actually fuse the pars fracture. So here's some intraoperative slides showing marking the midline, using the UCSS system, confirming the trajectory on AP lateral fluoroscopy. This is what kind of the incisions look like with injections of local. This is what we see during fluoro. A lot of people ask, why don't you use O-arm navigation? And I typically don't, only because the lamina tends to move a little bit during docking, and it can sort of alter the trajectory. So we like to have real-time fluoro. This is showing the Steinman pin going in, Steinman pin, and then looking at an O-arm intra-op to make sure the Steinman pin is perfectly placed over the fracture, 3D reconstruction, drill, tap, placement of the screw. And then once you do that, obviously the system is going to fail unless you actually fill the fracture site with bone. When we started doing the procedure, we would do a Metrex tube over the fracture site, and was a good way to fill with autograft, allograft, BMP. And this is showing a picture of that. We decorticate the defect, collect bone dust, put a little bit of BMP and autograft, allograft. This is obviously a off-label usage of that product. And then I got to put a plug in for my colleague, Dr. Basil, who you'll hear talk in a second, who's been helping now with endoscopic approaches to actually fill the defect. And this was a kid that we did where everything was the same as described, but instead of doing a Metrex tube, an endoscopic approach was used to fill the defect. And so these are some of the benefits of an endoscopic approach: smaller incision, more rapid recovery, less scar tissue. And on all these patients, because they're kind of like a prospective study, we do 1-year follow-up CT to make sure that the fracture is healed. And so we started this journey in 2012 with a paper that was sort of seen on the internet. And a lot of parents, are able to access it in this new age of Google. So we've gotten a lot of referrals through that approach. We're up to about 25 patients. You can see that a lot of these patients come from other places in the US and even outside the country. And one of the points of this slide is that all of them are sort of in the 12 to 18-year-old or 20-year-old. We're not doing anybody who's 40 or 50 or anything like that. We've published the results over time and followed those patients. And this is really my last slide. So whoever's up next, let's come on board. I think the most important is who should not have surgery, and because most patients don't need surgery. And those are people with not enough pain, not enough conservative treatment. If they have a listhesis, they're not a candidate. If they have foraminal stenosis, they're not a candidate. If they have radiculopathy, they're not a candidate. And many of these patients have very abnormal anatomy and that you can't actually put a screw across the pars fracture. And those patients, unfortunately, are not a candidate. So there's a lot of patients that we see that we say, we can't do the procedure. We've been highly selective, but it's been a fun ride and happy to take any questions. And if not, I'm going to pass the mic, unless there's a wine pairing.
Not yet.
Not yet.
Yeah, they'll let us know.
Then I'll pass it to Dr. Booth.
Open the discussion a little bit. Let's have a little, we're ahead of time. Thank you, Dr. Levy. Amazing talk. I have a question. What is the maximal age when someone can get a pars repaired? Because we were talking about this. What is the maximal age that you've found experience with that it could be successful? Is there a maximal age?
The oldest patient we have in the series is 25. I think I'm seeing a 42-year-old coming up, and I suspect he might not be a candidate, but you want to do it in young people because it's a tough heal. And, kids heal amazingly. So, I think that sort of pushed us towards younger people. And the other thing is by the time you get to 30 or 40 or 50, you start getting foraminal stenosis and you're just not a candidate anymore. So.
Yeah. So Alan, let me ask you the other question, which is you've been doing this for so long. You've had so much experience. What happens on the back end of this? In other words, 15 years after this, they were 22 when they had their original surgery. Now they're 40 something. Now they're getting classic degenerative problems. Do they still have to go through all those problems where they have a spondy and they need this fixed? Or is this something that we really should nip in the bud earlier?
Phenomenal question. So our first patient in 2012 was a hockey player. He was like D3. And so now he is like 13 years old. And now he's a lawyer. So basically I would tell you, he's like in his 30s now. So, you could argue theoretically to do this would obviate like a spondy and foraminal stenosis in the future. And it's something that we mentioned, but obviously that would not alone be a reason. The reason is pain, young kid, can't play sports, and that's the reason to do it.
You want to ask Scott?
Alan, is there any limit to how wide the defect that you'll not fix? Because the example you showed a pretty wide defect, but also it healed very nicely. So is there a limit?
No, I don't think so. I mean, again, it could be 1, 2, 3 millimeters. And as long as you fill it with bone, you're good. What we don't do, which is very different than an odontoid fracture, we do not use a lag screw. So we're not planning to like reduce the fracture with a lag screw. We just use a fully threaded screw. But the important thing is to fill that defect with bone, BMP, and et cetera. So that per se is not a contraindication.
Thank you.
All right. Good evening, everybody. My name is Greg Basil. I'm an assistant professor of neurosurgery here at the University of Miami, director of endoscopic spine surgery. And first of all, obviously, thank you to the Seattle Science Foundation for giving us this opportunity. Obviously, thank you, Dr. Wang, Dr. Levy, for setting this up for our department. Also, I want to actually briefly give a shout out to I don't know if you can see, that's our chief resident, one of our fellows in the background. We've put them outside as kind of extras here for this presentation tonight. So a big thank you to them. Okay, so let me start here with my disclosures. Okay, so I've been starting a lot of my talks lately, and I've been saying it's a really exciting time to be an endoscopic spine surgeon. But I'm gonna tailor that a little bit for this talk, and I'm gonna say it's a very exciting time to be a minimally invasive spine surgeon, because I think we're moving towards this idea of like a customized approach to spine surgery. And you might hear that and say, okay, Dr. Biz, what are you talking about? You're talking about like implants. And I think, yeah, implants are part of it. But if you look at this explosion of MIS spine surgery over the past 20 years, the number of approach corridors, the number of different procedures we have, they're kind of innumerous now, right? So I go back to when I was in medical school. I remember I read this book called The Emperor of All Maladies. It was this book about cancer, right? And the author talked about this idea that like the future of cancer treatment, it wasn't going to be like one drug that was going to cure everything. They're going to have a targeted therapy for each, cellular mutation, and they were going to pick which one hit that mutation. They were going to hit it with that. And I think we're moving to a place in spine surgery, maybe not quite there, but we have so many options. And so we can start really thinking about not just what can we do, but what's the best thing to do for the patient. And sometimes that means using two different things and using them in a synergistic way. So that's what I'm going to talk to you about here tonight. Hopefully you guys find it interesting. So let's get into the case. Pretty straightforward. It's a 58-year-old guy. He's not huge. He's probably like Miami standard. So, I don't know what exactly his BMI is, but probably less than 35. He comes into me with severe lower back pain and symptoms consistent with neurogenic claudication. And I know we have a pretty wide audience here. So just to be clear, what we're talking about was leg pain or leg heaviness when he would walk that would improve when he would bend forward, right? And the other key point to that was that he told me he had leg pain even when he was at rest, and his back pain was equal to his leg pain. Okay, so he's neurologically intact. So I want for a second just to show you the pain diagram here. And this is something we use here in Miami a lot. I'm not sure if this is standard across the country, but certainly it's standard for us here. And I think it's really, for me, important to my decision-making. And you can see when you see his pain diagram, he has a lot of back pain. He has buttock pain, pain down the back of the legs. We're going to stop. I've been told, sorry, we have our first intermission. And we have, so if we're going to actually stop sharing my slides for a second, just for this brief intermission, I believe they're bringing us in the crab. Are we capturing that on camera? Are you guys seeing the crab they're bringing here? Here, go ahead.
Listen, we forgot to tell you that any food and wine you drink, you have to send to all the participants here. And
okay, so we'll be sending out those bottles after. Do we have to send the crabs too? We'll put them on ice.
Yes,
so
absolutely.
Here's our
looks
crab
delicious. You're killing us.
Well, there's a red king crab from Norway. They're originally from Alaska. In Alaska, they have the laws where they are species from there, so they can't really be fishing them as much as they want to. They are only fished from August to December, pretty much. And then we have Norway, since it is an invasive species, you can just pretty much double the fishing period for that. And there's no laws. You can grab them, freeze them.
Don't encourage.
When it comes to Alaska, they have to pretty much kill them, cook them, and freeze them right on the boat. And in Alaska, they have to cook, and freeze on the boat, since if it's like originally from there, and they have like a lot of fishing laws for them. The only law that particularly pertains to Norway is that females are illegal to fish. You grab one, throw it back in the water. Yes, you'll occasionally have that occasion female that will be mixed up with all the males. There's so many crabs that it's easy for one of them to slip by. Mistakes happen, but usually you will not get a female. And yeah, they molt their skins. They pretty much eat the skin, because all of that nutrients in the old shell is what provides most of the nutrients for the new shell as well. I don't know what else to say.
It's fantastic.
And yeah,
All
would
right.
like to.
Do we have our?
I mean, it was pretty exhaustive. Would you
Here,
like me
let's
to?
give him the. Yep, we're gonna give our.
I mean, we've right now, so this crab is gonna be paired with a lovely Sancerre. So Sancerre Village, we're gonna do 100% Sauvignon Blanc from the Loire Valley. I went for an old school producer, which is the Comme La Font. So I think that the best way to pair something so buttery and creamy on its own will be with something that is extremely mineral and earthy driven. So I think it's gonna be a fantastic job, like together. I think it's just gonna come up, and I think the flavor are gonna mix up perfectly like that. We're gonna go ahead and bring Timmy back. Oh, unless you give him another name. Would you like to name?
All right.
Timmy's the man.
All right, guys. So that was our little brief intermission here. Let me get back to my slide. We're obviously trying to expand the education beyond just spine surgery here tonight. So here's a pain diagram. I already showed it to you guys. Back and leg pain equal. And I want to just introduce this concept of leg pain at rest. And again, going back to medical school, you guys remember this concept of like unstable angina, which is like they have like chest pain when they're just sitting. And I think about neurogenic claudication like that. If they have leg pain at rest, I think of that as almost like an unstable neurogenic claudication. And I'm going to come back to that in a minute in terms of what that means for my particular surgery. So here's the imaging. Not overly impressive on the X-ray. He's got a little bit of very subtle slip at 4.5. We can argue whether it moves a little bit or not. I think it probably moves very subtly, if not at all, but certainly a grade 1 slip there. Slight degeneration at 5.1. Here is the MRI. You see he's got severe central stenosis, facet hypertrophy. There's a broad-based disc bulge, bilateral lateral recess stenosis. So it makes sense, right? Exactly what we expect for neurogenic claudication. So the question is, like, what do you do for this guy? Equal back pain, equal leg pain, mildly obese. So for me, with a spondylolisthesis, certainly with some mobility, you know, and with significant component of back pain, I worry about just decompressing him and not fusing him, especially since back pain is a major part of his problem. He's also a little bit overweight, and he's tried to lose weight. He wasn't able to, so we could go send him to lose weight, and then, you know, and nothing was going to come of that. So in the end, I thought he needed a fusion surgery, but I was worried about a T-lift given his weight and the stress on that graft. And I was also worried about this unstable claudication. And we all understand this concept of indirect decompression. I think many of us will use this idea of leg pain at rest as a contraindication to indirect decompression. So then how do you kind of reconcile these two ideas? So for me, my solution for this particular gentleman was a lateral transpsoas approach to place a nice big lateral interbody cage, give him indirect decompression of his neuroforamina, but combine that with an endoscopic central decompression. And, you know, just to kind of, you know, walk through my logic here, I wanted to give him that larger footprint implant via the lateral approach to decrease my risk of subsidence with him. But I also wanted to couple it with a direct decompression. You know, in a patient with back pain, if I open him up, you know, what's the chance that I help his back pain, right? A lot of us say we don't do surgery for back pain, but sometimes we do, right? And so for me, by doing the central decompression endoscopically, it's like a sub-centimeter incision, very minimal pain postoperatively from that, and we kind of guarantee his results. But I think it's important to know your patient. This guy was part of what I call my pickleball series. So I have, you know, a bunch of pickleball patients that come to me. They started with one guy that I did an endoscopic surgery on, and then he did so well, they keep sending me patients. And these guys, they love pickleball. It's like the most important thing to them. They want to get back on the court as soon as possible. And he did not want to have a second surgery, because I think that's another important point. Like, you could have thought about maybe just doing the endoscopic decompression on its own and giving that time, and then doing the lateral or the fusion at a later date if necessary, versus doing the indirect decompression first and waiting on the endoscopic decompression. This guy was very definitive, you know, that he wanted like a you know, kind of a final treatment. And so we did the surgery. He had complete relief of his pain, 2 weeks post-operative, had no back pain, no leg pain, neurogenic claudication completely resolved. He's back on a pickleball court. He's happy. You know, so where do we take this from here? We've done a few patients like this since then. They've done so far very well, similar indications. You know, the question now, are we going to combine this with kind of a single position approach, do the decompression, the lateral position? If we're doing the lateral, you know, I think a lot of endoscopic surgery historically was done in lateral anyway. You know, most of us have gotten used to doing it prone, but that was kind of historically how it was done. So I think that's probably something that we have on the horizon in the future. That's it for me. Thank you so much. I'll take if there's any questions. Okay, then we're going to move on, I think, to Dr. Yurikov next, who's going to be giving his talk here. Thank you, guys.
Thanks so much, Greg. Great job. Let's see. Nelson, maybe I need your help on this one.
Oh, you have to go around.
Oh, hold on. There you go. Right, now back to Zoom. All right. Well, good evening. My name is Timur Yurikov. Thank you so much for including me in this awesome experience. I would like to share a case, or I guess a technical note that we have developed here. And the title is named Bowman versus Robot. I think that gives you guys a lot of pre-context already just from the name itself. As you know, high degree dysplastic spondylolisthesis, something that's been described a lot. It's a pretty rare condition, but when it does come, It poses several challenges to us as surgeons, usually presents in younger patients with a very already high and progressed level of disease requiring some kind of a fixation. And usually traditionally, the options include front, back, front, multiple approaches trying to traverse the disc space with a high sacral slope that's not otherwise accessible, either through a T-lift or A-lift approaches. And we would end up with these heavy-duty constructs. That would work, no doubt. But can we do it in a less invasive fashion? So since we got the robot at University of Miami Jackson Memorial, we've been experimenting with some of these techniques and seeing, can we really use the technology to our advantage? I would like to take you through this one particular case here, and then we'll go through more of a general discussion as well. So it starts up, of course, with positioning and preparation for the actual robotic part. There are several things that you have to keep in mind. The all-arm spin would include not only the spinal pathology, but also the black frame that the patient has to have on their back that would be part of the scan. So positioning on the bed, positioning within the OR room itself is very important. Placement of the percutaneous pin for the navigation array. Since the arm, as you will see later, the robotic arm will be all over the place, you want to plan it out that it's not going to be interfering with the robotic trajectory. Keeping in mind the crest line for the planning of the screws to be able to access some of them. And of course, as you can see, the middle screw has that oblique trajectory across across two levels. And you have to keep in mind that whatever rod you place, the tulip has a limitation on the angulation. So that has to be accommodated as well. Let me take you one by one, each level. Kind of, this is an overall picture, and I'll go into details. Starting with an L5, which is the top level, the one that has a high degree of listhesis. Usually there's anatomic variation that's involved, some kind of a defect or even transitional anatomy, and the pedicles are highly medialized. In an open fashion, to get to that trajectory, you will have to retract on this tissue a lot. A lot of times that's not possible, and many of these screws end up being laterally breached or out completely. Using the robotic approach with percutaneous access, you can see those screws can be placed with a very medialized trajectory and with the maximized biomechanical parameters on both the screw thickness and length. And also preservation of the facet joint that's right there, L4, L5, which otherwise becomes really damaged if you do an open surgery. Next screw is the one that we call tricortical screw. It starts at the inferior edge of S1 pedicle, traverses the pedicle into the end plate of S1, gets across the disc space, and then lodges itself in the inferior end plate of L5. And again, that high sacral slope, high degree of listhesis really accommodate for this type of trajectory. An intermediate step to it, right before placing the screw, you can see on the picture on the right, a funnel is placed, and through that funnel, bone graft is pushed into the L5-S1 disc space. And finally, the third screw to lock the construct down, I call it the Levy screw. It was popularized by Dr. Levy. At least I've seen this now for many years. Probably many people across the country think they've done it before and they've done it first, but I've seen Dr. Levy do it many years already ago. And this screw, in a way, it's an S2 alar screw, fully contained within the sacral alar, allowing you to maximize the length of the screw and really get the good thickness right into the anterior cortical bone. Again, with a robotic approach and robotic preoperative planning, these screws become easy to execute and they're quite reproducible. Also, the access for the screw goes right through the midline incision, which is not as big. And once the hardware is in, that same incision can be used to perform any of the gill fragment decompression, foraminal decompression, or placement of serolateral graft. And so you can see from these two videos, and you have to look left and right, preoperative planning and postoperative execution is pretty much millimeter to millimeter reproducible. And that's the advantage of having the robot. I don't think with even navigation, no matter how steady your hand is, you'll be able to get the symmetry and the accuracy of the screws in the same fashion. So this is where a robot really comes through as something that's a truly advantageous technology, allowing us to perform this case. So again, back to original Bowman versus robot. With the all patients do well, right? That's after a certain amount of time, but the operative time, as you know, for the front back is many hours. For this robotic procedure, it's around 2 hours. Blood loss, you can imagine, considerable difference. post-operative morbidity seems to be a lot more tolerable with the percutaneous approaches, just like we've seen at any other surgery. Of course, post-operative mobilization, hospital stay appear to be as well beneficial. And I'm being vague on purpose because for true statistical analysis, of course, I don't want to make false claims just yet. Of course, return to activities. I had to fight off a patient the other day who was 6 weeks post-op for this procedure, asking me, begging me to go on a scuba diving trip, which seems like she was ready to do, but I'm still not that confident as well myself. Of course, over long term, yet to be studied. We started doing this 3 years ago. And still, so far, I only have 4 cases, but with excellent outcomes and more than 1 year follow-up and positive CTs and positive fusion outcomes. Thank you.
Timur, this is Jack Ziegler. That was really that was wonderful. That's much more elegant than the case I scrubbed with when I was Henry Bowman's fellow. As you said, a lot of blood and hope and a prayer more than guidance. So we've come a long way in the decades since then. But that is very elegant, very nicely demonstrated.
Thank you, Dr. Ziegler.
Timur, for the grafting material, you just depend on the interbody graft. Is that correct? Or are you also doing posterolateral fusions?
Through that little midline incision that I do the S2 alar screws, that gives me access to posterolateral, that I can just do a conical exposure without opening the skin and muscle too much.
Okay, so you do a posterolateral and an interbody.
Yes.
Great. There was one question here. It says, do you need the S2 screw with the tricortical S1 screw?
It's an excellent question. Without the screw, can the construct last? Perhaps. That extra screw is not really taking much from the construct or a patient's morbidity post-operatively. It's an excellent biomechanically strong additional point. And now you have 3 points on the rod. If you just have those 2 tulips on the rod, there's still a chance for articulation across, especially that highly angled S1 traversing screw. So yes, I think the 3rd screw really enforces it and makes it quite rigid.
And Timur, one last question. Which robot did you use or do you use?
This was Globus Celsius.
Okay. That's very nice. Beautiful job.
Thank you. All right. Thank you, guys.
How is the crab?
We're still waiting for it.
Oh, I thought they were serving it.
We've got salads and tomatoes and.
They got to kill it first, Scott.
How is the Sancerre?
We don't have it yet.
Oh my goodness.
Miami time.
They're slow boating you.
Listen, I'm waiting for a drone delivery here in Dallas.
Okay, so Jack. Ziegler. I want to, while Michael Monterey setting up, Jack, I want to ask you something. Dallas, right? You guys are in Dallas?
Yeah.
Yes.
So we're showing a lot of new stuff, little edgy. It's very Miami, very South Beach. Does this sound crazy to you? Does it sound like nutcase stuff? Because Rod Ascuian's not here to help us. We got a bunch of Texas guys.
No, this is fine for Dallas. And listen, we're in the same band, the same band of the country. We're not in the Northeast. We're okay with this, Mike. This is all great stuff. We love it.
Okay. All right, we'll carry on here. So again, I'm Michael Monterey. I'm the new kid on the block, fresh attending here, fresh out of fellowship. So I'm going to talk a little bit about some dynamic visualization for MIS TLIF. So in preparation for this, I'll just kind of start off to kind of get where my mindset, because this is, MIS TLIF is something that everyone does. So let's try and think of a different spin of how to approach this and this procedure in general. So for instance, Medicare reimbursement rates are decreasing. This was actually presented at AANS recently that 20 of the most common neurosurgical procedures actually had an 11% drop over from 2002 to 2021. Also, what we know is what we talked about tonight is the advancement in technology, different surgical techniques, specifically MIS surgery, has allowed us to move our surgeries to an outpatient setting. And SG2, which is a healthcare consulting company, has predicted that, and this number is incredible to me, 85% of all healthcare procedures will be completed in an outpatient setting by 2028. And then furthermore, ambulatory surgery centers, which keep popping up and all throughout the country here, this results in significant Medicare savings. So all these things are something we have to keep in mind. And when we're, where's the future of spine surgery heading? Where's the future of healthcare? And how are we going to adapt to this? So this is just another slide to kind of reinforce what I'm already talking about. This is the total future savings. This graph here on the left of surgeries done at an ambulatory care center and Medicare spending, and the savings up to predicted to 12.2 billion by 2028. Again, huge number. And then this here on the right is just the most common surgeries, and you see nervous system surgery and the savings that would be associated with that. So obviously this is something that we have to keep an eye on and be important for us as spine surgeons. The other thing we have to think about is patient expectations. Previously, me, mom, and papa would just sit on the porch there, say, I had a good life. I'm going to sit in the rocker and just wait for the afterlife. Now we got this guy rocking out marathons, smoking cigarettes, whatever your choice, Parliament or marbles, what have you. So the expectation of what patients want is changing as well. Another way to reinforce this is a patient we saw that went out to go see our pain doctors. Our pain colleagues are very important to us. They're very vital to what we do as spine surgeons. But he had a prior spine surgery, didn't want to have further surgery, got the interspinous spacers, and one of those migrated and is impinging on the L5 nerve root, came back with terrible radiculopathy. So we took him back, took that out, doing much better. But that's not an indictment on pain doctors. We need those doctors. This is just more of a challenge that we're up against in terms of, other procedures are available. People are looking for the most minimally invasive surgery they can get to find relief. So all that being said, we'll get to the case here. And briefly, it's just a 70-year-old woman. She had a history of 3 prior decompressive surgeries. She presents with chronic left leg pain. And then here's some scalp films here. No significant movement. She does have a levoscoliosis there. Her pain diagram, very indicative. It's mostly left leg pain. Kind of points to the 4-5 area. And here's the MRI with the point of interest here. Disc here at the 4-5 level, eccentric to the left side, lateral recess, neuroforaminal stenosis, prior surgery at that level. So obviously there's a lot of different ways you can do this surgery. We elected to go for and do this in a minimally invasive technique using a technology of dynamic visualization. Now let's think about this. So let's say we're transitioned towards an ambulatory care center, right? Most common and most popular procedure at these centers is going to be colonoscopy. So the equipment we need is going to be, we have the tower already, right? So here we go. You got a tower, just have to hook up a camera for it. We have a peel pack, everything else from instrumentation to be able to have our retractor base off the pedicle there. So it minimizes the equipment that you would need for this ambulatory care center. So everything's already there. You don't need a microscope either to bring in. So this kind of allows you to transition this procedure potentially to that center. And this is just some intraoperative x-rays. That's our on the left there, docking of the tube there into the good position. You can see us doing the discectomy. This is a 15-millimeter tube that we're working through, 2 instruments doing our discectomy.
Sorry.
Oh, okay, interruption.
Time for the audience there.
Sorry.
One interruption. So for the next course, as I presented you earlier, I just want to show you the label so you guys can see it as well. This is the Comme la Fond Sancerre from Sancerre Village. As we said, 100% Sauvignon Blanc. It's going to be complementing your Norwegian king crab for your next course. All right? Thank you so much. Thank you, everyone.
All right, perfect. Elon Musk is going to help us transport that to Dallas for you. So again, back to the talk here, just have the intraoperative X-ray showing us docking the tube there. And then again, do the discectomy and moving forward. And here's just some intraoperative X-rays, or not X-rays, but pictures rather. I'm a big guy, 6'4", formerly athletic. Formerly athletic. But that's another thing that we have to think about as surgeons. How are we going to preserve our body? How are we going to preserve our career? Let's have a long-lasting career, go on for decades. For me, going under the microscope, doing other movements can be kind of cumbersome. This allows me to have stand up straight, good posture, looking at the screen and working intraoperatively. This is just a kind of closer picture of what we're working with. We did this one under fluoroscopy. I recently did another one where we did it with navigation. So also you can have good posture and you're also not wearing lead. So all those things can come into play here. And then finally, these are just the final intraoperative X-rays. She was a little more collapsed on the left side, so we decided to put our implant on that side to try and give more lift there. And what we thought were good intraoperative results. Post-operatively, she did very well within our hospital stay, had resolution of her radiculopathy. Seeing her back 6 months. Here's her post-operative pain diagram that we saw in clinic. You see the resolution of that radiculopathy. Obviously, we know she does have other degenerative levels, other bad levels, which is very common with patients that we see. We decided to focus on the worst level. And then her post-op 6-month X-rays, again, everything looking good. As again, levoscoliosis, but we weren't trying to fix that. We were just trying to fix her big problem. So, the other big picture thing, ambulatory surgery center, obviously we know 24 hours is kind of the limit of keeping a patient in that center. We've had patients that come and do post-op day 1, they're going home after the surgery with this technique. The other consideration is very sick patients. You want minimally, rheumatoid arthritis patients that are on DMARDs, they're going to have wound complications. These are all done through very tiny incisions where that risk of a dehiscence is very low. So ultimately, when we look in conclusion of what kind of the driving point that I'm thinking about here is, forces driving healthcare and technology. One of those is minimally invasive surgery. So estimated global MIS revenue for 2024 is estimated to be $79.3 billion. So that's, when you look at the finance behind that, that's going to drive a lot of different companies, a lot of innovation for, particularly for our field. The other thing is that we were alluded to, patient expectations as well as their desires. Ultimately, we know, it comes down to what we think is best for the patient and also what is best for us technically. And then cost reduction, and that cost reduction with Medicare, all those reports are being sent to Congress. How is this going to translate for policy decision-making in the future? So these are all kind of things that thinking about and the future of spine surgery. And that's all I have for you here tonight. So I'm welcome any questions. And that's just another picture for y'all to see what we're looking at.
Mike, that was such a clever use of the camera within the little, with your working port. And it probably gives you as much magnification as a microscope, I presume, because your microscopes, go ahead.
Yeah, no, and what's unique about it too is it's, I don't know, when you can turn the port and it turns the camera, so it allows you to look, am I looking medial? Am I looking lateral? And it's all kind of a clock. So 12 o'clock, 6 o'clock, or am I going to look cranially, 9 o'clock or 3 o'clock. So you have all those different directions to help you and navigate that. And so that 15 millimeter tube all of a sudden turns into potentially 20 millimeter, 24 millimeters, makes it a lot larger than you'd expect.
It's funny. It seems so obvious application, but you did it, and you've learned how to save money, especially in the outpatient procedure.
Right. And I think that the other aspect that you can think of it is, endoscopy is another route of this, but not all, neurosurgeons, maybe orthopedic surgeons are more familiar using scopes, things of that nature, but neurosurgeons may be, a little more hesitant to pick up endoscopy. So, but this is working through a tube is something that's very familiar to us.
Mike, so do you think this will be like a really useful stepping stone for people to transition to an endoscopic surgery, since the learning curve with the other is so steep and a lot of people just don't want to do it for that reason?
Yeah, I think kind of what I was saying, endoscopic, I think this is more favorable to people that, like the idea of endoscopy, but maybe they're a little hesitant to pick up that technology or learn that new skill set. But working through a port is very familiar and easier to adapt, and I think easier for them to adopt into their practice and work through it.
Okay, so we're gonna go into Norwegian crab, right? Yeah. I just want to say that the Texas group, Jack, Scott, Rick, you guys are amazing. This is a fantastic venue, and I want to give a shout out to a couple folks in Seattle. Linda, Corey, Rod. I mean, it's amazing. Seattle Science Foundation is amazing, right?
And don't forget Jens, even though he's not.
Jens. I'm sorry, Jens. He traumatized me. So I just want to hear a round of applause for them, for Seattle Science Foundation, please.
Now, do me a favor. Do not put one piece of crab in your meat in your mouth in front of us.
Oh, that's in Dallas, guys. That's in Dallas.
So
What's a crab, by the way?
So my name is Matthew Kumuk. I'm a assistant professor of neurosurgery here at the University of Miami. I have to thank, firstly, the Seattle Science Foundation for putting all this together, and all my incredible colleagues and mentors here tonight. I mean, we're incredibly lucky to be here at such an amazing place and talking about incredible things, and you know, really pushing the field forward and exploring these different types of techniques. So what I wanted to talk about tonight and just touch on really is kind of integrating prone transpsoas, that approach into your practice. It's something that I've found that I've been turning more and more towards. You know, I'm surrounded here by many Titans this evening, either directly around me or online. And really, you know, everybody seems to make it look easy when they've integrated a lot of these newer types of approaches into their techniques. However, I'm always very, very curious about how those first 10, 20, 30, 50 cases looked and what they learned and changed throughout that process as well. And so that's kind of my thought when I put together this talk, kind of some of my experience as I transition from either doing something through a minimally invasive TLIF or a direct lateral, and then why I'm now doing prone transpsoas as much as possible. Okay. Here are my disclosures, which are not relevant to anything tonight. Okay, so why prone transpsoas? Well, there's certain limitations, as we know, of direct lateral. There's time to flip, and really this is something that truly can't be underestimated. We saw a lot of amazing technology tonight, but I always think about, okay, where are we using this technology? Are you at that big academic center where you have the Army helping you? You have, you know, staff with fellows and residents and senior residents and chiefs and everybody else to help you do all of these things? Or are you in the community center where it's going to be very, very difficult to replicate some of these things? And basically it may just be you or one first assist doing some of these procedures. So really, time to flip, resources, they can be very vastly different through all these types of places, as we know. Obviously, there's limited access to the posterior column. I mean, we saw a lot of incredible procedures.
Are you showing slides?
I am. Can you see them?
Okay, you need to share your screen because we're not seeing them.
Help me out. Sorry. Thank you so much.
That's all right.
This one here. Yep.
Perfect. Can you see my screen now?
Yes.
Okay, perfect. Sorry about that. Thank you so much. So prone transpsoas, again, limitations of direct lateral, limited access to the posterior column. If you need to do two things at once, certainly that, you know, being able to tackle both of them at the same time within a physiologic or more physiologic corridor can be argued that prone lateral is better. Some of my colleagues here disagree, which hopefully should prove for some good discussion. I think it may be more difficult to achieve lordosis when the patient is in direct lateral versus prone lateral, where gravity is your friend, gravity is helping you. So some of these questions, again, on the bottom, prone lateral, is it more efficient? Is the anatomy safer? Is there more lordosis? Can you tackle more surgery with a dual approach? And these were some of my questions that, you know, when I started years ago thinking about this, when this, you know, generally came on the market or was introduced in 2019, why transition into this? We've all been trained, or many of us have been trained with direct lateral. Why switch now? And we, you know, wrote a lot of the papers about the outcome studies here with, you know, our team about many of the outcomes with that. So again, why prone transpsoas? Well, there is more retroperitoneal space. There have been studies, anatomic studies, that have shown that by placing the patient just in the prone position, you get more retroperitoneal space, okay? And in this study, they found that it was 8.7 centimeters versus 2.9 centimeters, okay? So what does the psoas muscle do when we place the patient in prone position versus lateral? Well, we found that, and by that I mean the author here, Amaral and colleagues, found that the psoas muscle moves more posterior, better lining up for a trajectory for a target to getting into that disc space while pushing the nerve bundle more posterior in a safer position, okay? They've also found that the femoral nerve is more posterior at the L4-5 level. That's a very difficult level to try and attack or try to reach at the in the lateral or prone lateral position. So anything you can do can certainly to help push that femoral nerve more posterior certainly would be helpful. And they found, again, in this anatomic study through 7 different dissections that the femoral nerve is located more posterior at L4-5. And some of the research shows that, again, there's increased lordosis for patients in this prone lateral position. You can see there on the right that the, let's see if I can see this a little better. Oh, there on the right, that the patients had a larger amount of lumbar lordosis. It's okay. So moving on to a case example, we're fortunate to have a lot of tools in our armamentarium. So I just wanted to show a case example of this, of an earlier case that I had with utilizing this technique. So I have a 62-year-old female with predominant complaint of severe low back pain. She had occasional bilateral lower extremity pain. She has a history of a gunshot wound with buckshot actually to the back of her head and neck. So she was not able to get a MRI, which I'll show you on the next image. And her BMI was about 33. And she's severely disabled by this pain, as most of our patients are. She's failed conservative therapy. She can walk less than a block with a walker. Here's her images, okay? So her anatomy is a little unique. She has a sacralized L5. There are some of her deformity parameters on the bottom. Mismatch, not too bad, about 13. Okay, and then based off the CT on the right, again, she's not able to get an MRI due to metal within her body. At L2-3, she has a grade 1 spondylolisthesis, and L3-4 as well. That slightly became worse at inflection, and then at L4-5, she has severe degenerative disc disease with about moderate central stenosis at all of those levels. So the question is, when you see a patient like this, when you see symptoms like this, certainly there's a lot of tools in our disposal. You know, we could certainly open things up here and see what everybody would do. I mean, there's a lot of different options. I know we've talked about. Okay. Okay.
Can we ask?
Would we?
Linda, are we on for more than 1 hour? 1 hour and 10, 1 hour and 15?
Linda, are we on for more than 1 hour? Dr. Wang is asking. Is it hour 15?
It's usually an hour, but this
1
is
hour.
1 hour.
Only 1 hour.
Only 1 hour.
But our opinions are so important.
Well, here, I'll ask. Okay. So anyways, many ways we can tackle this. Obviously, we're in a room with a lot of different amazing people, and again, amazing people online that would address this in many different ways. But what I decided to do is really address this with a single level A-lift, kind of a 360 approach. So the first level, L4-5 here, you can see we were able to introduce an interbody graft. And really, the first plan was a single level A-lift, but we were able to access, we have an amazing approach surgeon. So I was able to access the level above as well. So we went ahead and took it because it gave the anatomy gave us that, and we were able to open up that disc space, help to reduce that spondylolisthesis. So really left that last area for a prone transpsoas approach. And again, here's the patient positioning. Here's I took a seated approach to this procedure, and again, you'll see, at least on this procedure, this was done with fluoroscopy. And I'll tell you, just by looking at the pictures here, again, the patient positioning optimizes the patient's lordosis. I was able to get just some reduction of the spondylolisthesis just with the patient in that position. And I'm pretty comfortable. I mean, look at my neck, look at my position. I'm not bending down, crouching down. My neck is not at 90 degrees, looking down a hole where only I can see. So we're able to line things up and get into that interbody space without any complication, introduce the lateral graft into that space. And overall, and then with a posterior percutaneous fusion as well. And overall, I mean, the patient did very, very well. Mismatch was certainly improved. And then now at her most recent follow-up, she's doing amazing. She's kind of sprinting around the office, and she has minimal to no pain. She just complains of just a mild occasional muscle ache. So, since some of those early cases, as I've kind of moved forward, I mean, again, it depends where you're working. How good is your fluoroscopy tech? That first case that I showed you was with just fluoroscopy. Since then, obviously, we all know, depending on where you're working, if the fluoro tech is less than ideal, which it has to be perfect, as we know, I found a lot of improvement or standardization just by navigating the approach. We start out by putting in our screws, and we can pin, spin, and put the screws in less than about 20 minutes. The other wonderful thing is in cases like this, where there's adjacent segment disease, a little bit of a flat back, with severe central stenosis, we've been able to have a dual approach to this. So while I'm doing the interbody fusion, we can do the decompression at the same time. Okay. And just again, pros that I found over time is, again, it maximizes lordosis. We're able to reduce spondylolisthesis, and again, very ergonomic, seeing kind of my head position here. So again, for the people that are thinking about integrating into practice, if you can do lateral, consider prone lateral. Start with L2-3, 3-4 as you would with any lateral case. The incision is 1/3 of the posterior of the disc space, moving your incision posterior, and then certainly spending plenty of time in lab training mentors and colleagues.
Quick question on the case that you showed. Did you ask your access surgeon to see if he could get you to 2-3 since you already did 3-4 and 4-5 from the front? You're already there, or just patient's body habitus wouldn't allow that?
You're absolutely right. We did talk about that, and it wasn't safe enough to get up there.
Okay.
But yeah. Any other questions?
Matt, I do have a question. I never heard anybody articulate the way you did about the movement of the the plexus and the nerves. Is there any data to show that there's less nerve injury utilizing the prone position compared to lateral?
So, I think there's limited case series that have come out that show equivalent as far as equivalence of injury, or as far as, everybody wakes up with the lateral transpsoas, muscle irritation and thigh numbness, which, it's something that we wrote about here at University of Miami, that most of that is transient, gets better within about 3 months. But, the data is still coming out, absolutely, as far as if one is better than the other.
And second question, what about the learning curve, switching from lateral to prone? When did you feel comfortable?
I think, again, spending plenty of time in the lab, spending time with other surgeons that have been doing many, many cases. But I'll tell you, if you're able to do a lateral and you find a good case, and again, patient selection is key, like with anything we do, being able to find that and execute it safely is certainly been very much what I expected. And we can always bail and go to TLIF if needed.
I think we've got about 1 minute left. And I just, Matt worked with us in 2008 when he was a pre-med student looking at our case data in lateral, and to see him as a young faculty member, 15 years later is certainly gratifying. I'm going to leave the last word to Mike to close us out on an amazing evening.
So the chef called, this Norwegian crab is particularly tenacious. It has been a problem for us, but it is coming imminently. We will have to do this on a future SSF grand rounds. But I want to thank Greg Basil for doing an amazing job. He organized tonight. Thank you, Greg. We are going to do many more. Thank you, Linda. Thank you, Rick. Thank you, Scott. Thank you, Jack. This is amazing. We have to enjoin our colleagues in the world, wherever they are. Greg, close it out for us.
Wow, I wasn't expecting to get put on the spot there, but thank you guys for giving us a platform, for getting to, have all of our faculty up here, show what we're doing out here. It's honestly an honor and a privilege to us, and hopefully we can participate in the future. So thank you so much, and thank you for what you guys are doing.